Okay, surgical pathology of the vulva and perineum. Couple of key objectives today that we'll try to cover. Primarily just an overview of some of the benign and malignant lesions to be concerned with. Like to spend some time discussing controversies in staging or classification, and then just touch on reporting elements to remind you of those. Some of these things are based on practice, things that I've encountered. And relative to infectious disorders, there's really just one topic here I want to touch on, and that's the HPV infection. I'm sure you're aware of the association of that with vulvar condyloma and so forth. This is what they kind of look like clinically when they're very extensive. And you've seen the pictures. I've got digital slides in this presentation, and we'll just spend a minute or two and preview through some of those. You can see this very papillomatous appearance, and you will see variable amounts of viral cytopathic change with this perinuclear clearing and so forth. But in most routine condylomata, you don't see too much atypia in terms of nuclear atypia and so forth. You may see perikeratosis. So this is still within the realm of VIN1 or low-grade squamous intraepithelial lesion, as was defined by the last criteria from 2012. But the thing that I wanted to bring up is the question of child abuse. When you encounter one of these vulvar warts in a girl who's young, pre-pubertal and so forth, is this an indication of child abuse? And the answer is not necessarily. And that's specifically because many of these HPV-2 lesions, which can cause vulvar warts, are much more or are more common in the young adolescent age group, and are not specifically related to not related to sexual transmission. So this is one of those situations where doing HPV testing, typing on a vulvar lesion, especially in an adolescent, may be very helpful for you. If you can rule out HPV-2, then you may have a more likely situation of child abuse, but certainly don't jump to that conclusion until you've encountered that. Okay, so herpes, of course, is usually sexually transmitted, and just to look very, very briefly at a clinical slide of this, the area to look most closely, of course, is the area where you've got a vesicle. This will be the area where you can identify the characteristic inclusions, and I think you can see them here. There's some multinucleate cells here, and you see some nice washed out homogeneous inclusions in the nuclei here that are indicative of herpes. Now, of course, there are other viral diseases, and among them is this lesion here, which we will jump to. And you see here, this is characterized by these sort of bulbous downward projections. And you can see this even at low power. There's this sort of keratotic core, and then there's this sort of chartreuse or amphiphilic color that is indicative of the molluscum contagiosum inclusions. And we have some latecomers. They won't know about child abuse, so someone else will have to teach them. So when you're looking at this, you should be able to recognize this from very low power, but certainly don't. Occasionally they can be fairly hard to find, or maybe there's just one follicle where you'll find this molluscum contagiosum change. Now, there are other infections involving the vulva, chancroid, granuloma inguinale, syphilis, and so forth, necrotizing fasciitis, and so forth that can be involved. Here's a nice slide showing squamous mucosa, and then this inflammatory process with this serpiginous appearance, which as we go to higher magnification, you'll see is quite nicely illustrated as a palisaded granuloma with a necrotic center. So this is granuloma inguinale and characteristic of that entity when it occurs in the vulva. Okay, so let's go on to the skin diseases that we can encounter in the vulva. And I hope that some of you had a chance to look through some of my videos that we posted recently, where we talked a little bit about lichen sclerosus and its differential diagnosis, because I'm not going to spend a lot of time on that today. But suffice it to say, I think it's useful to approach skin diseases in the vulva by looking for the pattern. And so there are several key patterns to be aware of. Spongiotic pattern, which can be related to, allergic or contact dermatitis and so forth. The acanthotic pattern or a hyperplastic pattern. You can occasionally get psoriasis in this location, and certainly lichen simplex chronicus is very frequent here. And then the lichenoid pattern, which we associate with lichen sclerosus most commonly, but occasionally lichen planus. Now, there are other patterns that we can see as well. The sort of dermal homogenization pattern that is exclusively associated with lichen sclerosus. Vesicular bolus changes, IgA disease, pemphigoid. Acantholytic pattern, less commonly seen, but can appear. Granulomatous disease, and the vasculopathic pattern. So let's just go quickly here to an example here. How would we classify this? Well, we've got hyperkeratosis and we've got acanthosis, or a hyperplastic pattern here. Is this one of those entities that we've just covered? And as we look at it here, the thing that I think should strike you is this hyperkeratosis and these areas of hypergranulosis. That's one of the features of lichen simplex chronicus. And then you can also see some sort of vertically streaking collagen, along with these irregular downward projecting proliferations of squamous epithelium. So this is a nice example of lichen simplex chronicus. And rubbing is obviously a frequent problem when patients who become irritated down there, and you can get secondary lichen simplex changes fairly frequently. Now, just to touch on contact dermatitis in the vulva, this is just a short list of some of the irritants that can result in contact dermatitis. And so that can range from things like soaps to, wart medications, various solvents, and even weak irritants like deodorants and detergents, feminine sprays and so forth, semen, urine obviously are weak accumulative irritants and so forth, as well as other things. So these are all commonly present things, and common things are common. So don't forget to think about contact dermatitis when you see, especially that spongiotic pattern in the vulva. Lichen planus, as you can see here, this could easily be lichen sclerosus without the dermal homogenization. And the changes will usually be found primarily at the interface, where you may generally tend to get a little bit more ragged appearance. This doesn't have really good developed pointy, spokey areas, but there are a few in there to differentiate it from lichen sclerosus. As I indicated, I've put out a video which I'd encourage you to watch about lichen sclerosus, but this is the most common vulvar skin condition. We had a case yesterday, which also had some other combined changes, and it can be seen in pretty much any age group, but most commonly in the postmenopausal older age group of adults, and it has some autoimmune association. Typical low power appearance is kind of what you see here, with this homogenization zone beneath the epithelium, and then deep to that, the lichen component of inflammatory infiltration lower down. So natural history of lichen sclerosus, occasionally you'll have spontaneous remission. Treatment, sometimes with testosterone or other steroids, can be helpful, but it is associated with a lifetime increased risk of differentiated vulvar intraepithelial neoplasia and squamous carcinoma. And this is thought to be because it's following the p53 mutation pattern. And that actually is a useful differential. The case that I looked at yesterday had hyperplasia and had some atypia and this very lichenoid pattern. And I did a p53 stain, and it did not look like this. This is the homogeneous contiguous pattern of a differentiated VIN, whereas in lichen sclerosus, it's going to be patchy, more discontinuous pattern of staining with P53. And notice that this is only reflected in the basal layers. The surface, by higher up, you lose that staining pattern. So when I was a resident, we used to use the term vulvar dystrophy to describe cases where we had hyperplasia and some degree of hyperkeratosis and so forth. We don't use that anymore, but this benign squamous hyperplasia can be seen, and it may actually represent an early stage in the development of differentiated VIN. And so when you see those sorts of changes, be descriptive, tell them what you see, what's not there, and then certainly encourage follow-up in those sorts of circumstances. Squamous papillomatosis, which is a benign lesion and not related to condyloma. There's no coilocytotic changes with this. This is not an HPV lesion related issue in almost all cases. Most commonly, it's in the vestibule area. And whether it's a remnant of the hymenal ring or some other related sort of thing, it is usually present in women of reproductive age. And usually that's asymptomatic, but may be detected on exam and thought to be worrisome. Here's a representative image, and you can see you get this slight papillomatosis, but no coilocytotic change. We don't see any particular atypia here at all. Now, there are several pigmented lesions on the benign side of things that we can encounter as well. Most commonly, probably lentigo simplex or vulvar melanosis. This again is reproductive age lesion. These are usually small lesions, similar to the sort of thing that you can occasionally see in the lower lip macule or occasionally in the oral mucosal pigmentation. But there's really no nesting or atypia associated with this. We can develop nevi in this area, and of course we will talk briefly about melanoma later on if we get to that stage. So here's a nice image of what the vulvar melanosis would appear like. Hyperpigmentation along the squamo-submucosal junction and presence of pigmentation in the basal keratinocytes. Now, there are several cystic lesions that present in the vulva, and these are, oops, excuse me for that. These are lesions that can be oftentimes diagnosed clinically as Bartholin gland cyst, fairly frequently developed. And then there also are so-called mucinous and ciliated cysts, which may be Cowper's glands or vestibular cysts related. These tend to be ER/PR positive. And then, of course, just the usual epidermal inclusions. And rarely a mesothelial inclusion cyst, particularly if you're near where the round ligament would originate. Ectopic breast tissue, of course, can give you cystic changes as well. So here's an image of a Bartholin gland cyst. You see a fairly smooth lining, and some peripheral glandular tissue may be identified in these lesions. The lining is usually characteristically slightly stratified with a mucinous or transitional type epithelium. And then, of course, the Bartholin gland tissue deep to that can be seen. Squamous, mucinous vestibular cysts can also be seen, as we've indicated with this very bland endocervical-like mucinous epithelium. Vestibulitis, I don't think I've made this diagnosis, but it's supposedly fairly common in women of reproductive age. They can have point tenderness and absence of any other identifiable cause. And as far as at least the Saunders textbooks indicates, it sort of looks like this, with sort of a squamous metaplasia involving these vestibular glands, a little bit of edema, maybe some eosinophils in the surrounding tissue to indicate vulvar vestibulitis. Okay, so this is a Zoom meeting, and we're having Zuhn's vulvitis today as well. Plasma cell vulvitis, also called Zuhn's balanitis when it occurs in the males. This is associated with burning, red, multiple macules, and this is the vasculopathic pattern with sort of a plasma cellular infiltrate, thin ridges, and absence of any sort of granular or keratin layer. The deep keratinocytes can become somewhat sort of spongiotic because this is where things are turned, but this is where the inflammation is going on, and that's been termed sort of lozenge keratinocytes. So they look like little lozenges that you put in your mouth for a cough or something like that. The differential diagnosis includes syphilis, lichen planus, occasionally lichen sclerosus, perhaps. And just to show you at least one stage of this, I thought I'd pick a nice digital slide here. You can see this will look kind of blue. And so looking more closely at this, this is a case with a degree of epithelial atrophy or thinning. We see a very thinned layer here, and this very dense lichenoid band-like infiltration, which as we go into higher magnification, we can see is almost exclusively plasma cells. So you can see these are all just one after another back-to-back plasma cells. And that is a nice example of Zuhn's. It can be a little bit less pronounced, of course, in other circumstances. Let's talk about a few benign tumors that we'll encounter. I'm not going to cover the the mesenchymal lesions in the vulva. I did a video on those, and I hope that you watched that. If you didn't, go back and look at that, because you'll want to be familiar with those lesions as soft tissue lesions and the differential that comes up with them. This is another type of tumor occasionally encountered in the vulva, not the most frequent site. Here's a magnification, a higher magnification of how this looks under the microscope. You can see we have an intact squamous mucosa, and in the subjacent tissue, you develop this very pink neoplasm. So pink neoplasms, you usually think not very cellular, usually thinks mesenchymal, smooth muscle, or some other sort of thing. But this is a nice example of a granular cell tumor. You can have this very round nuclei, very small, not particularly atypical, and very granular cytoplasm with the characteristic staining features of this lesion. Okay, I'm going to jump down here a little bit to granulomatous vulvitis. So if you see granulomas in the vulva, you got to have three thoughts, and all three of them ought to be Crohn's disease. After that, then you can begin to think about other lesions, like infectious agents and so forth. So here's an example of this. We have a nice granulomatous inflammatory reaction here, mixed inflammation with associated giant cells and so forth. This would be our appropriately termed granulomatous vulvitis and would raise concern for Crohn's disease. Now, occasionally we can also get multinucleate cells within the epidermis. These are multinucleated keratinocytes. These are not the giant cells of granulomatous vulvitis. Another entity to be aware of is, of course, because we have sweat glands, this is an area where we can get hidradenitis. And this is an image of how that looks. At low magnification, you can see these subdermal or submucosal, subcutaneous abscess formation with variable amounts of residual epithelium related to the sweat glands, and potentially some relationship to the surface. Here's an example of the granulation tissue that you'll see in these lesions. I actually included a digital slide here. If you want to come back and take a look in greater detail, you can see that sometimes you get preservation of the epithelial elements with the surrounding tissues. Nodular fasciitis is one lesion that's not specific to the vulva, but can occasionally present there. This is a circumstance where you don't want to overdiagnose this, so you don't want to mistake this. And of course, Dr. Yu gave a wonderful talk about the UPS6 mutation that's found in most of the cases of this lesion. Characteristic spindle cell tissue culture type pattern. Sorry about that. A little glitch in the software. And we'll go down here to so there are other lesions that can confuse us. So sometimes you'll see stromal giant cells, and similar to those seen in fibroepithelial polyps. Occasionally you get ectopic breast tissue or other heterotopias here. And then, of course, the adnexal neoplasms, nodular hyperplasia, and Bartholin's lesions, and so forth. So I also did a video on adenoid cystic carcinoma. That's another entity to be concerned with occasionally in this area. So here's an example of these sort of stromal, slightly atypical cells that can be seen in vestibulovulvar fibroepithelial polyp, in breast tissue that you may get lactational change, especially if they're recently pregnant or pending delivery, nodular hyperplasia in the Bartholin's gland, and so forth. A frequently encountered neoplasm here is the apricot tumor called hidradenoma papilliferum. This is usually painless, under 2 centimeters, fairly well circumscribed. And you can have various components of epithelium, sebaceous, occasionally squamous differentiation. It can even resemble sclerosing adenosis in the breast. And so that's an important consideration. Here's an example, this nice sclerosing papilloma type of a picture with the sweat gland epithelium, as you see here on the right. So hidradenitis, hidradenoma papilliferum. Again, the epithelium is usually fairly simple, as you see here, associated with that. Now, there are other skin tumors that you can encounter here. Of course, sweat gland tumors like syringoma, hair shaft tumors, mixed tumor, and seborrheic keratosis. Some of these have actually been found to be associated with HPV-6. So that's an interesting association and may occasionally make the differentiation between a condyloma and a seborrheic keratosis somewhat challenging. So here's a nice example of a seborrheic keratosis. Now, we mentioned the breast tissue that can exist here. And so it's important to keep in mind the varieties of breast tumors, both benign and malignant, in situ and invasive, that can occur here. So that's kind of a quick survey through the lesions of the area that are mostly non-malignant. Let's take a look here at some of the issues associated with malignant proliferations. And this is a nice slide to start with because of the fact that on the one hand here we have sort of on the right the lichen sclerosis type pattern with this dermal homogenization. And here we have a sort of a differentiated VIN pattern. And then deep to that, we have an invasive squamous proliferation. Reminds us of this issue. So in terms of defining invasion, you of course know the criteria we use in terms of paradoxical keratinization down deep, irregular nests, irregular interfaces, jagged points, and so forth, parakeratotic pearls. Those are all characteristics of typical invasive neoplasia. But there can occasionally be more subtle patterns that almost at low power might look like sort of a vascular proliferation of granulation tissue. And if you didn't pick up on these red areas as being pearls or keratinization, you might think that they were small vessels. And so you have to be careful for this sort of granulation tissue-like pattern of invasion. So here's a case that I think is a digital slide on some of the lesions here. And so looking at low power here, we see, you know, a surface pattern. It's sort of undulating and so forth. We've got an ulceration over here. But there's a lot of sort of cystic change. And then we see some other areas down deep that may warrant further investigation. So I've highlighted here some of the areas where I think there's suspicion worth investigating. One is over here, this area down here, and then this area here. So let's look first at that first area. And we see there's some slight irregular keratinization here, but mostly just inflammation. So enough. Is this invasive? Well, probably we've got microinvasion in this area. And then where would we measure the depth to? Well, let's go to the next area. Let's look at this area that we highlighted. And if we look here, we can see some areas that look like this, a little bit like that vascular atypia pattern. And then, but, you know, you have to be aware of lesions like this, because if you just had this as your superficial biopsy, and they didn't get down to that level, boy, it could be really disconcerting. And if you just said, well, this is, you know, squamous mild VIN or something, low-grade VIN, they might not take this quite as seriously. So that biopsy came from right over here. But as we can see, this is the area where we've got invasion. This is the granulation tissue type invasion. And this, we had some irregular invasion here as well. So with differentiated VIN, underdiagnosis is a problem, both in terms of invasion and actually in terms of recognizing it as VIN. Because it's so highly differentiated, one study actually identified that 42% of lesions preceding squamous cell carcinoma were initially diagnosed as lichen sclerosis ended up being differentiated VIN. So it's not a trivial thing to struggle with that differential. And this is where your p53 stain could be very useful. So what are the clues to not miss this differentiated VIN? Well, if you see dyskeratotic cells, that's not a feature of lichen sclerosis. So you should be thinking you should be thinking of either differentiated VIN or potentially invasive. The abnormal squamous cells typically extend deeply into the epidermis, and they may form whorls or keratin pearls. If you've got large keratinocytes contrasting with smaller basal cells that have irregular nuclei and atypia, again, that's a feature. If you find mitotic figures in any of the upper layers, that's a feature, although not very commonly found in differentiated VIN. If you find mast cells, this is another clue. These are not usually found in benign cutaneous lesions or lichen sclerosis. They're often adjacent, but you need to pay attention. And as I said, p53, Ki67 can be very useful in this situation. There also are usual squamous cell carcinomas and subtypes, the warty type and the basaloid squamous cell squamous carcinoma, which are HPV-related pathways. And these are usually premenopausal women that develop this, rather than the differentiated VIN, which is a postmenopausal woman. And these also have other risk factors such as smoking and cervical cancer and so forth. So here's a nice image of a basaloid type squamous cell carcinoma. And these tend to be bad actors. In fact, just today I had a vaginal metastasis from a basaloid squamous cell carcinoma from 2 years ago. Okay, looking again at another circumstance. Again, this is sort of a usual. We see the scar here. We can see that we've got some atypia up here in the epidermis, go a little higher magnification. You can see an irregular infiltrated pattern and a surface poorly differentiated lesion. Here we see a little squamous pearl and the irregular generations of this. Another entity that occurs in the vulva is verrucous carcinoma. And that's, again, to be differentiated and slightly different than differentiated VIN. This is a mature, very well differentiated squamous proliferation that usually masquerades as sort of a verruca with a hypertrophic appearance. This has a separate pathogenesis. It's unrelated to HPV. It's not a p53 mutation type of lesion. And delayed diagnosis is not uncommon. However, this is not an aggressive neoplasm and rarely metastasizes. So you may be saved a little bit there. So here's an example. You get these long church spire-like papillae, papillary proliferation, variable hyper and hypogranulation, and then this basilar pushing appearance. Very well circumscribed. And as you'll see here at high magnification, really well differentiated. Very little atypia associated with this as you compare the top to the bottom. All right, so let's talk about some of the nuts and bolts, the staging criteria, and some of the issues. This, I think, actually a previous edition. You need to read through the notes of these protocols every now and then. Here's some recent information about grading. There are two systems in use. Kerman grading for invasive squamous carcinomas defines well differentiated as having discrete nests with keratinization and low-grade nuclear features. And then poorly differentiated with diffuse stromal invasion, small nests, no keratinization or very little, and high-grade nuclei. Okay, so that's great. We can do those. But then there's the middle ground, the moderately differentiated ones. And of note here is the important one that the basaloid or the warty, the large cell keratinizing versions, are usually not graded. The gynecologic oncology group has a slightly different grading system, 4-grade, which is based primarily on the amount that is undifferentiated. Small cells, scanty cytoplasm. Those are the undifferentiated cells. I don't use this, so don't ask me to get more specific than that. Staging, there's some important things to be aware of relative to staging. And of course, as you've no doubt recognized, one of the most important ones is how deeply invasive it is. And 1 millimeter is our important marker, especially because that's where the cutoff is to do inguinal lymph node dissections. Obviously, deeper invasion, more serious prognosis, greater need for radiotherapy or other adjuvant treatments, and so forth. The other issue, of course, is measuring thickness. Whoops, get rid of that. How do we get rid of that? Oops. Okay, well, we'll leave the distracting blue line there for a minute. Thickness of the tumor. So here's the instructions. Thickness of a squamous cell carcinoma is measured in millimeters from the surface of the tumor, or if there's keratinization, from the bottom of the granular layer to the deepest point of invasion. Okay, seems simple enough, but the depth of invasion of squamous carcinoma is defined as measurement in millimeters from the epithelial stromal junction of the adjacent most superficial dermal papillae to the deepest point of invasion. Now, if you read those and think those are different measurements, you're correct. But they are also defining different things. And so when you're going to measure the size of the tumor, you're going to measure the thickness. When you're going to measure depth of invasion, you're going to measure the depth of invasion. And so we only have a problem here is if we confuse these as being the same measurement. Now, to make matters more interesting, a few years ago, let's see, I got a way to, I wonder if I can erase. There we go, I can erase. I'll erase this thing. Okay, very good. A few years ago, some colleagues from the Netherlands proposed an alternative way to measure depth of invasion in vulvar squamous cell carcinoma. And essentially, they produced this diagram. And define different levels. So I said the depth of the tumor is the surface of the tumor to the deepest point of invasion, or if it's got keratinization from the granular layer to the deepest point of tumor invasion. The FIGO staging, the standard FIGO staging, measures from here, this A measurement, to the deepest point of invasion. Okay, so notice we didn't measure from here, we measured from here. So the most superficial measure of invasion. Now, these are important distinctions here because obviously, you know, if this is 0.97 and this is 1.05, you're going to get a different outcome. Well, our colleagues in the Netherlands proposed measuring thickness from this point, from the deepest point of the nearest normal reedy or semi-normal reedy to the depth of invasion. So that's a very different measurement, obviously, than this one. Now, here's a nice illustration. Which is it? Okay, so if this is the measurement here, that's their measurement, as opposed to A, which would be stage 3A. Is it 1A or 3A? This is obviously not a trivial question. And the data from their study were fairly compelling. However, the numbers in their study are not huge. So here is a graphic comparing the FIGO stage using the conventional method as opposed to their method. And so as you can see, not surprisingly, a number of 1B cases in the total study. Of the 69 1B cases, 13 were downgraded using their method to 1A, as would be expected. And one that was 3A was downgraded to 1A. So that was probably this case, whereas you can see this would be a very thin measurement versus this would be a very deep measurement. Now, which really is it? In some senses, this makes an enormous amount of sense in terms of the biological stage of progression of invasion. You know, this would seem like this is a more recent event than something which has on the whole would have this depth A of invasion. And so it's understandable, perhaps, why with low numbers of these sorts of cases, their survival curve looks so great. So this is what their survival curve looks like using their 1A cases, and they had no disease-specific recurrences. And the 1Bs had a few. But I think we're going to need to continue to watch this. You may practice at some point in a facility where they have some preference for different ways, particularly if you're practicing in Europe. But currently in the United States, we're using the FIGO standard method of staging. And so that's the measurement you should report. However, there may be cases where this kind of information may enter into discussion. So what's the etiology for squamous carcinomas in the vulva? Well, there are two principal pathways that we've mentioned. The classic pathway, which progresses through VIN and is associated with the high-risk HPV viruses, usually 16, more commonly than 18. And it's similar to that which we see in the cervix. It can be multifocal, more common in younger women, and have a somewhat lower risk of progression into invasive squamous carcinoma. These will always be P16 positive, but usually negative with P53. And the invasive component tends to be basaloid or somewhat warty. The second pathway is that we've mentioned with differentiated VIN, which is a P53 mutation-related pathway, usually in older women. And occasionally, or at least more recently, some HPV subtypes have been associated with this, although it's interesting that these lesions are typically P16 negative. Taking a further look at just the differentiation between the basaloid squamous cell carcinoma and keratinizing squamous carcinoma, more commonly typical keratinizing, less commonly basaloid, younger, older, multifocal, unifocal, commonly associated with HPVs and lower genital tract disease elsewhere versus rarely. warty versus purely keratinizing, and then associated VIN, yes, typically present. If present, it's the differentiated type, and HPV types and so forth. So that's just a nice sort of summary from Dr. McCluggage's textbook. So let's evaluate how you've done here. I'm going to pick on somebody to see who's asleep. So here's a 45-year-old female, has an abnormal pap test, treated with cryosurgery at age 25. She's been monogamous since 31. Now she has an exam with a reddened area on the vulva that's 2 by 1.5 cm and no palpable adenopathy. Here is her lesion. As you can see, at low power, it's very blue. It's a little bit thickened. Go to higher magnification here. You can see more of that. You can see the atypia, full thickness. Here's some areas of budding and so forth from it. And another slide. So here's the measured depth, 1.52 millimeters. So let's see, Beth, does she need to have a lymph node dissection? I'm going to unmute you. Hello, Beth, are you awake?
You unmuted me.
I tried to unmute everyone, but somebody won't unmute. Okay, so Philip, I'll let you answer.
So don't you have to measure from like the most superficial papilla, not from the surface?
Right. So would you measure from here?
Yeah.
Or here?
I guess I probably would, even though it looks a little tangential, but I think that probably is true.
Yeah, so that is the point I wanted to point here, is that this is a tangential, slightly tangential section, and so you really have to be careful about whether or not you measure from the surface or even from one of these very superficial papillae if you're going kind of at an angle. So the follow-up in her case was that she did have a sentinel lymphadenectomy and no evidence of metastasis. But I think she probably, I think if we had been a little wiser and a little more astute, measured not from the surface here, but maybe from a more reasonable superficial papillae, recognizing we're going, that she might have fallen just under 1 millimeter and have avoided that follow-up. Okay. So let's go on here and talk about Paget's disease. We've got a few minutes left. Now, there's also a nice video on this if you want to peruse the channel if you didn't see that earlier, but there was a discussion of this. So about 30% of patients who have Paget's disease of the vulva have some synchronous or metachronous internal carcinoma. Unclear why that is, but you would have to postulate that probably since it's not immediate metastasis, that it may be something more of the nature of a field effect kind of change. Certainly 95 or more % of these cases are all in situ adenocarcinomas in the vulva and do not have an underlying urothelial or Bartholin's or rectal carcinoma, but that needs to be considered because 5% is not zero. And as you know, we use markers to help define these. Some of the more useful ones are HER2, P53, CCA, CK7, and so forth, which will stain distinctly differently from that. Gross appearance, this can look kind of mottled, irregular. This is obviously very widespread Paget's disease. I don't think most of the cases that present in our institution are this widespread. And the characteristic appearance of this, single cells or small clusters of cells along the dermal epidermal junction with upward migration, very frequently seen, with single cells. And because of that, of course, the differential includes things like melanoma, as well as adenocarcinoma in situ or Paget's disease. Here's a higher magnification. You see that the cytoplasm and the nuclear features are different than the surrounding keratinocytes, and it's useful to take a look at those. Here's another image. Occasionally we'll get signet ring type cells or little intracellular lumina can be seen in these cases as well. A little caveat to be aware is that sometimes there's a secondary squamous hyperplasia. You saw in the gross image how there was kind of a rough and bubbly appearance, and sometimes these can be associated with almost warty-like squamous proliferation along with that. And so some cases have occasionally been mistaken for squamous cell carcinomas of the sort of clonal type, or seborrheic keratosis of the clonal type. That is in the differential as well. I'll give you that slide twice. So here's a CK7 stain showing a nice upward migration with this CK7 stain. Mentioned the differential diagnosis includes malignant melanoma, Pagetoid VIN, or VIN with mucinous differentiation. That would be a little bit unusual. And then other lesions, Spitz-Nevis, Merkel cells, Langerhans cells. These are very uncommon lesions. If you see one, please show it to me. I haven't seen them yet, and so forth. Carcinoma is associated with the Bartholin's gland. Certainly, most commonly, we will see squamous carcinoma rising in the duct. We had a case excised that they thought was a Bartholin's gland cyst, turned out to be squamous carcinoma. To identify it as being primary there, you'd like to see some sort of transition from the normal gland to the tumor, or it involves the area of the Bartholin's gland, or is consistent with that. And you can see adenoid cystic carcinomas. Again, there's a video about that in this location. So here's a nice example. Here we see a little transition from Bartholin's gland here, and then we see in situ neoplasia and invasive neoplasia, which would be certainly enough to establish the diagnosis of Bartholin's gland and neoplasia. And then just because we love to look at these lesions, here's the adenoid cystic carcinoma that also can occur in the Bartholin's gland. Now, there are obviously other carcinomas that we can see here. I've mentioned Merkel cells, neoplasias, mammary type neoplasms, adnexal carcinomas, mucinous, sebaceous, and so forth, basal cell, and so forth. Let's see, where do we want to go? So let's take a minute or two, the last few minutes, and talk about vulvar melanomas. These are not an insignificant number of vulvar neoplasms. 5 to 10% is far from zero. Again, these are usually older women that may present with itching or bleeding or some sort of a change. Unfortunately, many of these present at stage 3 or 4 at presentation, and that's really unfortunate. In terms of establishing depth, it's a little bit difficult here because we don't have quite the same dermal structure. So applying Clark's level is a little bit more difficult unless it's out on the, the perineum or out on the labia majora. But if it's on the labia minora, you're not going to have the typical Clark's level to measure. Breslow's depth can be used, of course, but many of these have sort of an undulating surface, and defining where is the actual deepest point of invasion is difficult. So there's a modification that is probably, I think, what's in the CAP checklist. Level 2, less than 1 millimeter, level 3, 1 to 2 millimeters, and level 4, greater than 2 millimeters. Staging for melanoma, less than 1.5 millimeters, this should be millimeters, not meters, in depth, or Clark's level 3 and no Mets. You see that's stage 1. Stage 2, slightly thicker, at no Mets. Stage 3, nodal Mets, distant Mets, and so forth. Here's a nice gross image. You can see the pigmentation. As I indicated, it can be somewhat nodular and undulating and so forth, and therefore difficult to ascertain. Under the microscope, of course, here's why it can be difficult to distinguish from Paget's disease. Question?
Girl emailed you the groups for part 3.
Okay, so someone had a question. I'm not sure why I'm getting logged out here all the time. All right, so we'll go down here a little further. We're just about to the end. This is more the in situ component. We don't see the dermal component here, but you should see this upward migration of the melanocytes as an indication of malignancy. Now, this is not totally diagnostic because there are occasional benign circumstances in which you can get upward migration of melanocytes. Irritation and so forth is one of those things, and certainly the vulva can be irritated. But in the appropriate setting, upward migration is a good indicator of malignancy. Obviously, the morphology on these lesions and the invasive component can be typical, can be epithelioid, nested patterns, but you can also get spindle cell versions or something more like this that can masquerade, especially if they're sparsely pigmented for other pigmented or for other spindle cell lesions like leiomyoma and so forth. All right, one other entity to just cover very quickly. Smooth muscle tumors are rather uncommon in the vulva, but do occur. Pregnancy seems to prompt their growth. And in terms of criteria for malignancy, the literature gives us essentially 3 or more of the following: greater than 5 millimeters in size, centimeters in size, greater than 5 centimeters in size, greater than 5 mitoses per high power field, per 10 high power field, and moderate to severe atypia, tumor cell necrosis, or any other features of that sort. If you're lacking that, you've got those other sorts of things, calling it an atypical smooth muscle tumor for those that lack the full criteria for smooth muscle neoplasm sarcoma. All right, myxoid leiomyosarcomas or myxoid leiomyomas can occur in this area as well, and these, as you can imagine, can be somewhat challenging to diagnose. Leiomyosarcoma with mitotic activity, some degree of nuclear pleomorphism, cellularity that you would see and associated with that. And then occasionally epithelioid types can occur here as well. There are a few even more exotic and unusual lesions to be concerned about that you may encounter here. Germ cell tumors occasionally can involve this area. Soft tissue neoplasms like rhabdomyosarcoma, liposarcoma, especially in the sort of mesothelial end of the round ligament kind of area. Just like you get a periscrotal leiomyosarcoma, you can get the same thing in the vulva. Rhabdoid tumors and other kind of one-of-a-kind omas can be found in the vulva as well. Okay, so I actually finished faster than I thought I would. Didn't show you, didn't spend as much time, so we have 5 minutes for questions. And I tried to unmute everyone, but it's just not responding. Well, it says unmuted, but you've gone back and muted. So anybody have any questions, comments, feedback? Okay.